CareAsOne is committed to providing a unique virtual collaborative experience for healthcare professionals to come together to exchange information about U.S. healthcare through collaboration, conversation, and knowledge sharing. The Future of Health podcast provides a true infotainment service that helps the industry innovate by sharing expert voices, views, and advice on the important issues of the day. And now here's your host for The Future of Health, Dipty Desai.
Hello, everyone. Welcome to The Future of Health with CareAsOne. I'm Dipty Desai, the director of CareAsOne and the host of this podcast series. For those of you who are new to CareAsOne, it is a large virtual community that brings together various stakeholders in the care cycle, from providers to payers, pharma to clinical researchers, startups, investors, universities, and more. The mission of CareAsOne is to truly care as one by creating a connected healthcare community where the patient is at the center of care. The entire ecosystem comes together to care as one through knowledge sharing with the help of healthcare experts and luminaries, thought leaders that will discuss the challenge gaps, solutions, and transformations essential to make healthcare whole again. The interaction and networking between the stakeholders are made possible through the community and via summits, webinars, roundtables, leadership circles, and podcasts. In today's podcast on digital transformation in healthcare, I will be talking to Kash Patel, the new Chief Information and Digital Engagement Officer for Hackensack Meridian Health. Hackensack Health has grown by merger and acquisition into New Jersey's largest health network. Kash previously served as a Chief Digital Technology Officer, leading innovation, digital transformation, infrastructure, and software development at the Perlman School of Medicine. Kash is a technology leader, business-focused, outcomes-driven, an entrepreneur, and a strategic thinker. He has more than 2 decades of IT experience in healthcare at other organizations. He served as a vice president of population health and analytics for 12 years at Mount Sinai Health System in New York City. Before that, he developed software and managed delivery teams for companies such as Avaya. And his experience in healthcare is undeniable. And today, he will be discussing with us how digital is transforming healthcare. Kash, it is truly an honor to host you today. And to begin with, can you please tell our listeners a little bit about yourself, your role at Hackensack Meridian, what you and your team are focusing on every day, and maybe you can also touch on the journey that brought to you where you are today. Kash?
Thank you, Dipty. First of all, let me thank you for having me on the podcast, and thank you for that introduction. It was a rather it was a very nice introduction. So thank you. So
it was truly what you have accomplished. So it was really a pleasure to have somebody like you to be introduced to here for this podcast.
So, Hackensack Meridian, as you sort of touched on it, it's 2 large health systems merged. We actually had 3. So I shouldn't. So there are actually 3 systems that have merged into one. We have 9 campuses, 18 hospitals, the largest sort of network in New Jersey. And what that means is it's complex. And my role here is, they've been on the search for a CIO type for a little while. And what's attracted me to join Hackensack Meridian Health Network is they're really poised, the leadership team, the board, the sort of vision is poised to not sort of obviously continuing the wonderful traditional health care and services that we do within New Jersey, but also to expand business, to expand different ways of providing health, challenge sort of the norm, think about different healthcare models. We've opened up a med school a few years ago, and this round of students graduated. So we had pretty amazing accomplishment. We're pretty nascent in the world of research compared to some of my previous organizations, but there's a well-developed internal strategy to increase that, very formally in line with the School of Medicine. So that sort of framework sets me up in terms of, my role. I'm blessed to walk in to have an amazing team here at Hackensack Meridian. They have gone through COVID. When there's no hiding it, we had a terrible experience with malware here several years ago. The team have done a phenomenal job of managing that risk, addressing it. All our 18 hospitals are now, proud to say, all on Epic. And we were doing all of this, while COVID was sort of happening. So it was a lot of change, a lot of organization. And the team that did all of that is the team sort of, I've inherited. I'm super proud to walk in to have a really high functioning team. The areas that I'm going to focus on in my sort of journey here at Hackensack is around what I would say the things that are keeping up the leadership and the board awake. So strategy around data is a really good example of, we have a pretty amazing data team. We do analytics, we do reporting, we do all the stuff that keeps the business alive. But then what question is what sort of, what we're going to try and answer. We want to get in the world of genomics, precision medicine, more predictive care, AI modeling, using data as a tool to run the business fundamentally, as opposed to sort of a service type of thing. We're going to set up a data science function. We're going to set up a more formal structure around DevOps. So these are all areas around data and development. We're also going to have precision, sort of the personalized medicine piece and the digital enablement piece around medicine reporting up to me. So we'll have a whole new patient journey conversation. So these are some of the big topics that we're doing. A little bit about my journey.
Yeah, wow, that's truly, you're on your path to transforming this healthcare system, and it's impressive. I mean, you just joined like maybe a couple of years ago, and I was unfortunate the pandemic hit, but maybe that was also fortunate because, it really made this whole organization go through this transformation. And I guess the whole world had to embrace this digital transformation, and it created these do or die scenarios in healthcare. And you did a fantastic job of adopting these technologies. Maybe what you can tell our listeners a little bit more about that, on some of the decision making that you had to take, and its impacts, and the technologies that enable the transformation, not only on the front end, which is patient facing, but also the back end that none of us see. You mentioned malware and security, and those are important topics when you're talking about healthcare operations. So can you tell us a little bit more of some of these areas that we just talked about?
Yeah, when COVID happened, like for many of us in healthcare, there's nothing like a common cause to get united by, right? And between the nurses, the IT staff, the doctors, the leaders, everybody gets behind this sort of common mission around addressing COVID. And, one thing that one has to acknowledge is true here. We're a large organization. We are a large organization. Decision-making is complicated, right? It takes time, and there's influence and changes and budgets and approvals. We all see that. COVID really changed that. The decision-making process was quicker, clearer. We did not fear making a bad decision. It was, if we made a mistake, we would say, all right, that didn't work, we're going to try something new. So, the obvious things hit us. Being in healthcare, we knew about COVID, maybe I'd say days or weeks before it sort of hit the public, right? But it wasn't sort of in the mode of shutting down business. And then from a back-end perspective, the obvious answer was, can we work from home? Do we have enough licenses? Do we have enough infrastructure? Do we have enough machines? Do people need laptops, right? All the obvious stuff that tons of organizations went through, right? And lots of licensing agreements, lots of change, lots of infrastructure. That happened with hindsight, that kind of happened in hours. It didn't take months to make those decisions. We were fortunate, and this is where some of our infrastructure play sort of comes into it. We were sort of starting to standardize on the back end towards Google anyway. We weren't there when COVID started. We sort of were sort of more common infrastructure. But the fact that we were working on common infrastructure sort of helped us with the abilities to sort of get everybody sort of working remotely quickly. more realistically, and more sort of, I think, more interesting was how did the business, if you recall early on, all of us had the regulatory reporting components with the federal government and the state government, and there was an awful lot of requirements. Patients that were scheduled for non-urgent medical care did not come into the hospital, right? So when patients started to schedule, we had to figure out how do you triage that before they turned up at the door, right? And so there's a whole stack of technologies, mobile technologies through our EMR environment around screening. And so we were jumping to screening initially, and then obviously we jumped to telemedicine, right? And we had multiple telemedicine platforms, and then the challenge was trying to get consistent and workflow. So a lot of the puzzles that are the health system experience, maybe our approach was a little different. That was sort of the early on experience.
Yeah,
so.
No, it's great what you mentioned. I like what you said, that, you made decisions quickly, good or bad, and you were not scared to make those decisions. And that's how you make changes in your business processes, your business challenges, etc. Use technology to enable all of that, your remote work, your shortages, maybe telehealth, etc. And transitioning to something new is always difficult, right? When you have the patient's lives at stake and providers want to make those changes. For example, we are moving from that fee-for-service to value-based care, right? And providers have to make that change, but they're hesitant, right? And you, I think, are doing this like a pro. So can you tell us a little bit about how providers are navigating this transition in the virtual model of value-based you would like to shed some light on?
Sure. No, it's an interesting puzzle. I think it's quite complicated, right? There's a legislation component, there's a change in behavior component, and then there's a sort of operationalizing all of that. And so if I start sort of with the legislation piece for a moment, in the sort of when we had the Democrats sort of running, we had Obamacare, and it came up with sort of measures and metrics. Those programs didn't really continue in the Republican world, but the value-based care contracts did continue. So that sort of complexity, you have to get very sort of nuanced around it. And so the initial fear from a physician perspective was, I make my money if I see a patient in the office, right? And so how do you have the conversation? And it's an honest business conversation to have around, if we do screening and wellness and we do all of these things virtual, we still have to make sure that the care is there and then the revenue is there too. And it's a black and white conversation. Legislation allows us to do that. Conversations with our payers and contractors allowed us to do that. And ultimately what you find, and I've done this now at multiple organizations, what you find is we actually end up having better outcomes because we're doing more screening up front, we're engaging with the patients up front, and we actually get to see sicker patients in the hospital setting. And so the people that need care in person are seen in the hospital setting, and the ones that have, say, chronic conditions that are manageable, say diabetes, for example, that sort of manage chronic conditions, stay at home and have lesser in-person visits, right? And now legislation has also allowed us to sort of, right? And there was some, confusion there. Now legislation is a lot clearer. I think COVID has accelerated that for sure. And now we can do telemedicine. And so our virtual care models have telemedicine experiences all integrated. When you make appointments online, it says in person or virtual, right? It's all more or less available now consistently. And, we're moving, we have a very large home health business. So it's not just the visit piece where we actually have a capability to send nurses and staff to the patient's home, right? We do infusion care, for example. We provide services at home. So there's a whole new way of looking at this virtualized care now at home. And we'll talk about it in a moment as sort of the next new world of hospital at home.
Yeah, no, that's true. I mean, in a way, the pandemic has been like a blessing in disguise. It's kind of like accelerated this adoption of technology that you see in care. And I just wish that for value-based care, there was possibly that you could create a blueprint or a roadmap. And I think people like you who would help create those blueprints and roadmaps would make it easier for the rest of the people by writing up a how-to guide or something like that for health IT initiatives, maybe a checklist that provides tips on how to buy in, how to choose tech, how to launch, how to track progress, stuff like that. I don't know. Do you have something like that, or how do you do this?
It's a good idea. No, I resonate to that idea. It makes sense. one of the things that I found challenging is, each business is sort of done locally by the state, and so it gets very complicated or sophisticated. I don't think you have to be sophisticated to understand the guidelines within each state. And so some programs were sort of metric driven, some were outcome driven, some were sort of experience driven. So each payer conversation turns into, how much of your premium, if you will, of your risk that you're taking is based upon a value-based care, what's measurable and what's not sort of measurable, right? So I think I'm not sure we've created or we're at the stage where we can create a succinct list that works, but I think we're moving in that direction. I do think there's, every state is now doing this, right? It's not a localized thing. Now every state's doing this. Every payer has these programs, some small, some larger. Even the large traditional hospitals that have, large inpatient patient volume beds are now looking at the value-based care model seriously. So I think the more we do this, the more standardized it will become. And I think that's the world from a technology perspective. When the business becomes standardized, we can then start to scale our technology approach.
Yeah. And people like you will be leading the charge and being pioneers in doing something like that, so many others can learn from. So also today in hospital systems, we often hear about remote patient monitoring. You mentioned about telehealth, population risk stratification, right? Because when you look at a population as a whole, now you'll get deeper insights, the digital front door, virtual care. How can you use all of this data that you're collecting to help build a better personalized patient engagement strategy? It would be good if you could tell our listeners a little bit more about how can one thing transform the lives of the patients by using all of that data that you're collecting in the back end.
Patient satisfaction is an important topic for us to understand, to measure. It's really a genuinely sincere way to get feedback on that engagement, right? And so examples around engagement with the patient at home, we have done multiple surveys, both localized that we've done and then nationally published ones around if the patient feels engaged with their care provider and their care team, if they feel that the physicians and the nurse team are listening to them, right? They're much more likely to adhere to the medication. They're going to adhere to the guidance. If the physician says you need to exercise or diet, even for non-critical, issues, even if they are post sort of surgery and they're talking about wound care, for example, if they feel engaged, there's much more adherence to the guidance. And as soon as there's adherence to the guidance, it's scientifically proven that the outcomes are significantly better, right? And so this is all around getting more engagement. Hackensack specifically has really focused on social determinants, in a way that we can actually then analyze and discrete. Years ago, social captured as literally in the notes by the social sort of services team. Now they're discrete elements in the EMR, which we can run analytics on. So we can start to see who's homeless, but not only homeless, their English is a secondary language, they live on a third floor lockup, they don't have transport, for example, right? And now we sort of begin to engage services around with like the likes of Lyft and Uber, and there are various companies around transport, for example, to send vehicles or a mechanism to their home so they can make that doctor's visit, right? Example around technology, I'll give you, this is a very real example. Sort of the classic case, somebody's got asthma, somebody who's, English is a second language, they have an asthma attack, they go to the emergency department. The emergency doctors will take care of them, absolutely, will, give them medication and give them advice, and then they go home. A week later, they have another episode, they go to the emergency department, right? The same thing happens, they send them home, right? So this is sort of a model. What we've intervened now with technology is that when the first episode happens, that's the first time we're seeing the patient. We didn't know them. I'm making up a scenario, right? We didn't know them. Now they're in our system. What we do is we do send them home, but what we do is technically we connect them with a local service provider, for example, a social team, a charity team, a community organization, right? And we connect them up formally, electronically, digitally. They then connect with They go and identify, say, somebody who speaks that person's language, say it's Spanish, for example, and they go and find a Spanish-speaking person in that community. So what we do is we educate that person. If you have an asthma episode, again, speak to your community connection, right? Your community provider, your advocate, for example, right? that advocate is, when the advocate's, they then encourage that person to go to see the GP and not go to the emergency. Then person might say, I don't have transport. Well, now we've taken care of that. We send, transport services. They go and see their GP, and then the GP is able to train that person on how to take the medication, go home and then have a better outcome. All of this means is, on the business side, the cost to the health system is significantly reduced. 2 episodes in an emergency setting is a lot of money. Right, but much, much, much more importantly, and something that really resonates to me personally, is the person's outcome was significantly better. Right, they were more satisfied with the care. They were able to speak to somebody who understood their language, understood their symptoms, have an advocate that could speak on their behalf, and then the adherence to medication was significantly better. This is a true story with a real patient that's happened sort of in real life, and this is what technology at home, enables.
Making it possible. That's great. I mean, you just gave example of a patient, and collecting some data on the patient allowed you to get much better outcomes. And so many patients like me are generating tons of data, right? We have products that we are collecting data, but there's so much data out there that people don't know what to do with it. I mean, is that something that providers can leverage and do data analytics on, and identify high-risk patients, tailor personalized outcomes and outreach plans, and measure care programs and outcomes? Do you see that happening in the near future?
Part of Google here at Hackensack Meridian, we'll talk about that, but we're basically standardized on Google. And part of that standardization is now I get a seat at the table where we can influence some of their roadmaps. We actually had a customer advisory board yesterday, which is the first one I sat on with Google. And this very topic was discussed, right? Is how do you handle this veracity of data from all of these different sources, right? And so I've been at the other end of the conversation multiple times as a physician, for example, right? And the physician would say, all of this stuff is just too voluminous, right? What am I going to do with it? You come in with like 6 pages of your fit. What am I going to do with it, right? The patient thinks it's really important. They were adhering, they were running, they were exercising, they got their calorie burns and all of that, stuff that the doctor told them to do. And the physician is looking for something a lot more succinct, right? And so this is where the analytics play into it. This is where the brainiacs at Google sort of come into this, right? Is that if we can get all of that quote unquote raw data from all of these devices that may or may not be FDA calibrated, right? I mean, the consumer devices are not calibrated and not certified as a medical device, but they have a lot of good data. So we can create actionable insights that have credibility to a physician in a form that the physician can then consume. So we might say some benchmark of 1,000 steps a month. Again, I'm making something up non-clinically, but we can create a score, right? And if the analytics can create a score, we can then validate that clinically. That will be of significant interest to the physician, because then it becomes somebody's done the math behind all the numbers, but so clinically it's been sort of validated, and it starts to give me trend data than which I can then act upon, right? Because just like a lab result, the trends are just as meaningful as the absolute result. So I think that's where a lot of thinking is going, and even the device manufacturers are sort of plugging into this sort of thinking. I think we're working with Google. Other partners are sort of working with Google to. If we could effectively build an ecosystem of that kind of thinking, then I think really starts to make that kind of data very valuable.
I mean, taking all that data and making intelligence out of it, right? And that brings me to the next part of it. Like, we all talk about artificial intelligence. I've been hearing it since the 80s and the 90s, and now we have the third wave of AI coming out. But this time, it's really making a difference. And seeing so many applications in healthcare, enhancing patient care experience. I know you mentioned Google. Google's like an expert in AI and modeling for machine intelligence. So can you talk about some of these advanced technologies in AI that are being used today in the hospital by you and some of your peers?
Yeah, it's a fascinating subject. I would be the first one to say that, you know, this sort of world of AI, it's not mainstream that it's sort of, you turn it on and it works, right? What all the use cases, and there are some phenomenal examples, and, you know, and I'll give you some examples. You know, we've done some sort of modeling around radiology images, right, for example, and you take those images and the sort of the basic use cases that can help you prioritize what you should read first versus second, right? But think about that, and you know, the specific use case I'm sort of having in mind is a digital pathology. There's an awful lot of data available historically, and now that we're talking about the genomics, precision medicine, personalized care, there's a lot of data available already in images that we haven't mined, right? And so while the sequencing data is sort of the new kid on the block, as it were, relatively speaking, we have a ton of old data in these images, and so we're building AI algorithms in this space to scan all of those images, for example, to create new phenotypes that we can start to associate with. And then we have sequencing data, we can create phenotypes out of that. And then we're now creating sort of new sets of knowledge to go and mine. So there's an example of the AI algorithms that have to be trained, obviously, and learned, but then you can then sort of point them into the old image archives, and then they're going to go and create a set of new phenotypes that would not be humanly possible. And over time, the training gets better and better, the AI gets cleverer and cleverer, and we start to see more accurate assumptions. This is not the stuff that you can just turn on and say it works. This is the stuff that does require strong discipline to say, I've turned it on, now I'm monitoring it, how many patients, how much real care changed, right? How many real sort of patients were impacted. I mean, that, you know, if we're being candid about it, the world of genomics and sort of drug approvals from an FDA approved perspective, you can count on, you know, it's a relatively small number. We haven't hit the hundreds and hundreds of sort of approvals yet, right? But a lot of conversations around it. But the AI world is sort of narrow and deep, and I think that's sort of where it's at today. And there'll be some breakthrough when it sort of starts to become mainstream.
We just at the tip of that iceberg for AI. We have so much more to uncover. There's so much, like you mentioned, from genomic sequencing of babies to figure out what's going on, at least the ones that are high risk, to, you know, maybe something else in the future. So, I was going to say, you know, there's also a parallel discussion around, you know, when you say it that way around the baby example, but there's always a stack of ethical sort of consideration that need to be caught up, right? Is that, do you really want to know that your baby's going to have a certain disease if it's not actionable? I don't know. I don't have the answer to that, right? So there's an awful lot of, I think, human consciousness that has to sort of happen in parallel too. So. Yeah. And so true for healthcare, right? I mean, it's not like a software that you put out there and you can say, I'll do a version 2 of it. With healthcare, there's so many ramifications and implications that you have to consider: social, economic, etc. So yeah, there's a lot to think about. No wonder healthcare tends to be slower than the enterprises out there that adopt technology much more rapidly.
There's large focus now on existing medications and repurposing those medications for other disease sets. I think actually the pharmacogenomic examples are what I would say real in terms of their ability to impact change quicker than a new drug development. So.
Yeah, I mean, designer drugs for the individual, right? Based on genomic data that we could gather. Yeah. Well, but going back to Google, I was just going to say, I mean, it's great you adopted Google as the cloud platform, and there's so many cloud platforms out there, and there's so many tech tools out there to choose from. Of course, Google is like the best in AI, I guess, too. So why Google and why now?
You know, this is one of the reasons I've joined Hackensack. They have an app change, and I'm loving it, and I say that with a lot of excitement. And so the Google decision is an example of that appetite. We're not only Google Cloud, we're standardized on Google. We have Google Chromebooks, we're using Google Workspace, we're using, we are moving to Google 100%. We have Google in our clinical environments now, our Epic front screens, our Chromebooks, for example, right? So we figured it out. We figured out how to do that. There's some, legacy applications that don't run on Google, and we figured out how they work and how to put them all of that. So fundamentally, we're a Google environment across the board, right? And what that helps us with is to start to have a strategic conversation with the likes of Google, right? And we the sort of senior leadership around this is to say, all right, now how can Hackensack, who's Hackensack Meridian Health, is a forward-thinking, a forward-thinking health system. We've adopted, we've proven, we've seen. And so how does Hackensack Meridian Health partner with Google to affect change, right? We've got about 4, what I would say, fascinating projects that we're working on with Google. AI modeling is sort of one of them. Around sort of cancer discovery is another one. And these are all in the hopper, as it were, right now. We have some amazing scientists there, access to some amazing Google talent. We're building all the infrastructure and the data pipelines and the integrations. But we're creating the engine. We're creating the engine to do this. This isn't a you try one experiment and it works, it's going to cure everything. We're creating the mechanism, coupled with our nascent our medical school and our growing appetite for research. We're hiring, known primary sort of investigators that are renowned, and we're sort of beginning to increase that. And so we're going from about $20 to $30 million grants, and typically the NIH, to about over $100 million. And those are journeys. They don't happen again overnight, but we need foundational work in place, right? And so Google is part of our foundational work to move in that direction.
That's great. Great choice. I mean, they're doing so much in healthcare. It's amazing. But I also work with technology startups, and there's so many startups out there that are making some amazing solutions. And to those startups, what would you say? They want to work with hospital systems. And I can understand how hard it is for a hospital system to pick a startup versus an established organization, right? So what would you say? Is there a path for startups that are solving longitudinal studies in diabetes, or reversing diabetes, or chronic care management, etc.? What can they do to attract your attention? Is there a protocol that they need to follow? How can they get onto your radar?
Yeah, somebody who's been in the startup world, before I sort of got into healthcare, I had my own startup and building technology solutions. And as a small company that grew to 200, getting the attention of a decision maker, I have been through that trouble. I've been at the other end in a healthcare environment, selecting startups or talking to them, right? It's a really hard answer to sort of say, here's the model that sort of works. My advice to startups, and I was collaborative when I was in sort of New York City that were evaluating and sort of supporting startups. Mm-hmm. My advice consistently has been around, they have to pay an awful lot of attention, even as a small company, around security. Patient data is sacred to any organization. No hospital was really willing to put their data into the cloud. I mean, that was the norm. And now I wouldn't even say everybody is still comfortable there, but much more are doing that now, right? So there's an example about how security sort of trumps that. The first thing is, what are you doing with security? And so any startup, go and get your environment, independently assess from a security pins. Answer that question the first time you speak with somebody, and so therefore they sense that. The second thing I would ask them to do is to think about scale. Large health systems always worry when they talk about startup. These are 2 guys in the garage, and as soon as we put 5 patients through a system, it's going to break, right? And so they have to be able to answer how they're going to scale. They don't have to have proven it or have done it, but they have to be able to sort of speak to the scale thing. And the third and most important thing is know your use case. Don't walk in saying we can cure world hunger, we're going to cure diabetes, don't do that, because you're talking to people who live and breathe this stuff for a living, and you come in and say, I'm going to cure diabetes, we're done, we're conversation's finished, right? But if you have a cohort of patients, we've got statistically, we've proven with our studies that we can reduce the A1C by 20% over a 3-month period using our program for over 21s and under 50-year-olds, for example, right? That are, et cetera, et cetera, et cetera. So narrow your use case, understand your use case, go in with a very, very understood conversation to somebody. Then they say, wow, that's interesting, let's try that out. And then you start to have the conversation about what if. And I think that's sort of the interview thing, right? That's the interview, the thing. So these people know what they're talking about. I can trust them. They seem competent. Now let's sort of dig a little deeper. Don't walk in and say, I can do this, I can do this, I can do this. That gets all gray very quickly.
So I guess to startups out there, they have to pay attention to security, scale, specificity, and then build that trust factor, right? When you get to CEO. I think that's good advice for them. So good. And then I had one more question, but wanted to talk to you about, I've always wondered, coming from India, I know that we do healthcare quite differently than we do healthcare in US. And one thing that India is toying with is this unique health identifier, I feel, like Ayushman Bharat initiative, the health stack, and identifying one. We have a social security over here in the US, which we can't use for healthcare purposes, right? So it would be great to create a unique patient identifier. Some of the hospital systems have done that, adopted that, but most have not. What are your thoughts? This unique patient identifier to put the patient back at the center of care and providing everything along so that now you can integrate all of the data, no matter what source it comes from. It can be all put together and insights can be gleaned from it. Different people can get different access. I'm just throwing it out and would love to get your thoughts on that.
So I was a long time ago, I was a part of a program with the UN, and we did tours in Africa, and we went to Ghana and other countries in Africa, and we studied the India model. And one of the things about legislation in America and other countries, it's different, right? India, in the Ayushman Bhavan piece, we have retinal scanning in India, right? And so they've got biological identity through the retinal scan. They were looking at that model in Ghana to provide this. Ghana is a relatively African third world country, provides basic national care for about $200 a year to all their population, right? And they have identity. I support the single identity model for sure. I grew up in England. We have a national health system over there, and there's a national insurance number. I've had these discussions both at the sort of federal level, the state level. I've been in many conversations. I think fundamentally our constitution protects the individual person's right. And so as soon as we sort of assign a label to that person, a number, for example, a tracking number, it starts to get into my constitutional right conversation. I do, though, technically speaking, and again, I do remember this conversation with people at Google X when Google X was around. I do think the answer could be, and if you think about it, right, most patients feel, if they think about it a little, the data belongs to me. It doesn't belong to the doctor. It doesn't belong to the hospital. It doesn't belong to pharma. It belongs to me, right? And we don't really think of data that way as a healthcare system, for example, right? But if you sort of technically speak about it, if I had a little thumb drive, for example, and I had my encrypted key on this in some cryptocurrency type of model, Bitcoin, however you want to talk about it. If I had my encrypted, I could go to any physician anywhere in the world, give my key to them, and they could see my healthcare data, right? And what does that mean technically? It means we need an honest broker in the middle of all of this. We need an honest broker that doesn't own the key or sell the key, but we need an honest broker to act as the master, key holder, right, in this piece. And the question is, who becomes that honest broker? It can't be an Epic, it can't be a Cerner. It could be the federal government. It could be, possibly, right? It can't be Google, whatever it is, right? It can't be one of those. But I remember talking to legislators in forums about at least if legislation took that on and they could create the mechanism of an honest broker. That's not saying we're going to give an identity to everybody. That's not saying that, but it allows the user to either trust or not trust, but they would be the honest broker. And I think if we could do that, then we could get to what you're talking about, is having a single trusted source of the master key, what we then know is where all the health data is all connected.
And that could be the future. That could be the future of health. But talking about, all this technology adoption is actually bringing in new ways of doing business, right? And there's so many, and it becomes the whole universe opens up to us. So if you were to make some decisions, where would you like to see some of these technology adoptions, the future? Where would you like to see them focused on?
That's a very broad question. That's a very, I mean, that's a very broad question. But what we're sort of on slightly differently is, I think we should all be focusing on, and lots of people are, is how the individual patient is consuming health. We all talk about these models about going to an Amazon or Walmart, ordering something online, for example. It arrives the next day. I want to return it. I can return it. It's relatively hassle-free, et cetera, et cetera. Mm-hmm. And if you could extend something like that, the ease of use, the ease of access, the transparency, how much things are going to cost. I can make an appointment when I want to make an appointment. I know my meds are going to get renewed. I know how much they're going to cost sort of before they get renewed, right? If we could do the consumption of health and make it as seamless and simple as possible, I'm convinced that the other end of it will get better adherence, will get better outcomes, will get a better transparency in the whole process. The access to, we have a huge challenge in America. We have a large challenge around access to health for the underserved communities. And I think talking about trying to find technology to address the access to health to underserved communities is an area where I know I'm going to focus. As soon as I've built some stuff here at Hackensack, we're going to be focusing on that area for sure.
Yeah, no, that's great. I conversations we are talking about, we've come a long way in healthcare. I mean, 30, 40, 50 years ago, patients used to be visited by their doctors at home, right? People came, they made individual family visits, and people got to know the family, they got to know everything about them. And then we said, that's not scalable. For it to scale, we need to bring the people to the hospitals, right? And we did that. We created these structures, the hospitals, people came, patients came, they scheduled the appointments, got to know. Soon it became too impersonal, but at the same time, there's a lot more technology that has gone into it. And you were toying with this idea of creating this hospital at home. Do you want to elaborate a little bit more on that? That seems quite intriguing.
Yeah, it's a very, very early stage sort of thinking. The regulations are allowing, in very narrow cases, provide a inpatient setting at home, and so it is not for serious conditions. It's for the level 1 or level 1 condition. And so if you come in the hospital today exhibiting, say, COVID symptoms, right? Traditionally, you may have been you may have been admitted, but in some clinical cases, they will say, go home and rest. But what we're going to do is we're going to, from a technology perspective, but more from a business perspective, treat that person as if they were a patient in a in-hospital setting. Which means, right, if you're in a hospital setting, you have doctors and you have nurses and you have care, you have monitoring going on. Now, while you might not need the full intensive stack that a hospital building would provide, you need the assurity that there's a nurse, there's a doctor, there's care around. So we're starting to brainstorm around what technology you would put in the home, what's invasive, what's not invasive. The simple thing about having a camera in the room. Now, obviously, you want the camera to be initiated by the patient, but think about this, right? If the patient is at falls risk and has fallen out of their bed, you want the camera to turn on immediately, right? And so there's this kind of thinking about the privacy pieces and how much monitoring are you going to put at home, how much monitoring the person can handle. Do we put the technology in the bed, or are we going to do these sort of weight scales and stuff? So we're beginning to have this conversation about what is essential, what's sort of nice to have. There are businesses out there already. Some states are doing this. I know, and some large facilities are doing this. It's a growing area. It's relatively new. Legislation hasn't caught up. The waivers are sort of a 1-year thing. They haven't sort of given a carte blanche, unlimited type of thing, right? And so it's not as if there's going to be a lot of long-term investment today. But think about what happened at COVID, right? COVID times, nationally, we were running out of beds. Some states, some cities ran out of beds. We started to put beds in parking lots, right? In shopping centers, in conference rooms, etc. Right? I remember setting up beds in New York City at the Javits Center, for example, right? And so these are things that happened. These things that happened. We had a pandemic. This is what we did. If you create elasticity in the system and have a mechanism to put beds in the hospital, and we could triage that a certain type of risk can be managed at home, that starts to help our ability as a nation to handle this kind of stuff in the future too. That's not the only reason, but think about the macro level approach to that way of thinking. So I think legislation is is changing. Lots of states are looking at this, and we're just doing our due diligence and our sort of thinking on how we're going to operationalize something like this.
Thank you. So COVID has its pluses and minuses. On the plus side, it definitely enhanced and accelerated technology adoption for healthcare. So thank you, Kash, for taking this time to talk to us, to chat with us, and share your knowledge with us. And to the audience out there, we have, thank you for listening. And don't forget to check the show notes for the links and resources and contact information related to today's show. And you can tune in for more CareAsOne podcasts and discussions on trending healthcare topics that you care about.